Welcome to this special edition of Around the Rheum. We're coming to you with daily roundups of the most interesting and essential topics from the CRA's annual scientific meeting here in downtown Calgary, Alberta. We've taken Around the Rheum on the road this week, and I'm happy to be joined in person by my very excellent co-host, Dr. Janet Pope. How are you?
Pretty good, and another great day.
I
feel like it's the Olympics. Another great day at the Olympics.
Yeah, it was a great day. I really loved the sessions today. And back with us again today are two of our very best scientists to help break things down on day 2 of the ASM for you. The University of Alberta's Dr. Mo Osman. Mo is also the abstract chair and co-chair of the ASM Planning Committee, and the University of Calgary's Dr. Marinka Twilt, who is the ASM Program Committee Chair. Welcome back to you both.
Thank you.
Thank you very much.
So lots happening here today on day 2 in Calgary, so let's get into it. Maybe today we'll start with Dr. Osman. Let's turn things to you. What sort of 3 topics or presentations stood out to you from today's sessions?
I felt the abstract podium sessions this morning started off with a bang. All of them were fantastic, but the one that really stood out to me was the one by Archita Shiranat. She's a PhD student with Nigel Haroon in Toronto, and she really simplified some really cool in vivo work related to a ubiquitin ligase and how this kind of was changing the inflammatory response and kind of shifting the inflammatory response to a Th17 IL-23 type of mechanism, which is relevant obviously to SPA. So I thought this was really cool. So good for her, honestly. And obviously we had fantastic speakers, but this was the one that really stood out to me. The state-of-the-art lecture was amazing, for lack of a better word. So I am biased. I am a scleroderma physician, and my colleague, Dr. Nancy Maltez, gave a fantastic state-of-the-art, and she really kind of highlighted where we are when it comes to cellular therapies in systemic sclerosis. And she touched on a lot of the challenges, but also opportunities, I think, which I thought was fantastic and I would say realistic.
Yeah.
Because I transplant many of my patients because I send them to Calgary, and she touched on this also, how we have 2 transplant centers that do the majority of the transplants in Canada, and she was sharing some real data related to some of the challenges around this.
I think that with that presentation, it definitely did kind of remind me of like the heme room overlap, that we really do have a lot of crosstalk and like a lot that we need to learn from them for sure, but also vice versa. Like a lot of our diseases, I think, do overlap somewhat, or there's crosstalk there.
I completely agree. And I think to kind of further agree with you, we've taken a lot of their therapies into rheumatology, and she highlighted some of those other kind of therapies and how relevant they are, or maybe will be, to rheumatology. Which I thought was phenomenal. I thought she did a great job.
Agreed. I think she did such an excellent job, and I think you had mentioned she was pinch hitting for someone who couldn't make it, and she did really just such an exceptional job. I thought that was a great talk.
Yeah. The workshop that I attended, which I enjoyed, again, I'm very biased. I am a scleroderma physician. I attended Sabrina Hua and Mei Choi's workshop related to demystifying autoantibodies, and it was very interactive, and I felt that they brought back something I really enjoyed, which was real immunofluorescence in rheumatology and what it means, which was something I felt like I hadn't seen in a few years. And it was nice to kind of remember what some of these things actually meant.
I know that we've kind of clinically moved very much away from like immunofluorescence at our center, right? We do ELISAs for everything. And I at least did go through training when we were still doing immunofluorescence, and I miss it. It was, I liked kind of thinking about patterns and the why of the different patterns, and also like our ANCAs, the old P ANCA and C ANCA.
Yes.
I
It's
know
nostalgic.
Yeah.
But it also helped you to sort of parcel out in your mind the various diagnoses. Yes.
Right.
So I like the patterns.
Right, totally. We had those like atypical ANCA patterns that kind of gave us clinical information, and now we have to be a little bit more precise about, why is the PR3 positive, why is the MPO positive, even though we may end up in similar places. So those are great presentations. Maybe, Marinka, we can go over to you. What were some topics that caught your eye today?
Yeah, I'll start with the end of the day. So I'll start with the great debate. Be it resolved that MSK or POCUS should be a mandatory component of rheumatology curricula. And Dr. Brian Feldman and Dr. Carol Hitchen were debating against it, and Dr. Michael Stein and Julia Brooks for it. And I think just that Julia was there as a physiotherapist and had to go first and really was thrown for the wolves, as she said it.
Yeah.
I think it just showed really a really good balanced debate. I think it was really nice. There was enough science that you could really understand why they divided for or against. And I think actually it was still unresolved by the time we were done. But I think in a really nice, respectful, but also still very funny way of discussing a matter. So I think that was really, for me, a highlight. It's always a highlight, a great debate, but this one, again, was very good.
Absolutely. And Janet, we don't know how everyone individually voted.
But you
Janet,
heard me cheer on the. I actually tweeted as Pocus Hocus.
Yeah. What's your take on it? Like, you've been training residents for a long time, and you have a lot of clinical skills and do a lot of teaching. I am curious about your insight based on what was presented there.
Right. So I think, like anything, there's believers and disbelievers. So what I'm always concerned about is what's the added value over my clinical care? Because if I have too much sensitivity, am I picking up things that are maybe not relevant, and also maybe they're relevant, but they're not tenosynovitis. They're regular people tendonitis. So that's one thing. The other kind of, I'm not discouraged. I'm glad that people might be all in and are learning, and I know there is a role in that they can help my patients at certain times, somebody that's a skilled ultrasonographer. But I'm kind of concerned that, in a couple weekends, people feel they actually have the skill set. And I mean, it takes a long time to learn ultrasound for even an ultrasound technician. I know they're doing all sorts of body parts, and this is MSK. But my concerns, I think, are the ability to have the retest reproducibility on the operator of it if you're only doing it casually, a machine that's maybe not good enough, and over detection. Mm-hmm. So that's where I'm kind of on the fence, but I'm sure there are times that it comes in handy. MTPs that are subluxed, is there synovitis there, a shoulder or a hip that we can't easily see and would like imaging on spot, somebody that it's not fitting in, CRP's up, but joints look good, just see if there's Doppler flow, because grayscale isn't going to change what I do, but high Doppler might. Right. So there are indications, but I don't know that it should be mandatory. I think it should be considered the way PGY sixes and beyonds do extra training. So I kind of like that point at the end that, sure, why don't you train later and get sufficient enough training to be competent in going to wherever site you're going to go to.
I sort of feel like whichever side you land on, recognizing it as a complex skill that requires a high level of training to be good at it, to answer the tough questions that we have, not to tell me if a swollen joint is swollen, but to tell me about these more complicated situations. I think an unexpected result of ultrasound being much more common at my center is that I do feel a little less confident in my own clinical exam. And research won't capture that, and that's probably not most people's experience. But I always wonder in the back of my head about the synovitis I haven't found. And maybe that's a good thing, or maybe that makes me an overly cautious clinician. I don't know about that. What else caught your eye?
Yeah, so one of the workshops I attended was the must-shoots and aspires of the new transition clinical practice guidelines. And one, I shout out for these people because they also were the ones that were asked 2 weeks ago, because this was the workshop that we couldn't let happen because of the NIH restrictions. So that was one. And they really did a fabulous job in explaining how they came to these guidelines, how they use the adopt, or de novo approach of developing the guideline. It's not yet endorsed by the CRA, but it really, I think, is ready for it. And I think this is another topic that I think we always overlook, because I think we all are struggling with it, not just us, but I think all subspecialties, with the transition process of our patients, and even what is the correct transition time, right? It's 18 here, and I think 18 is actually the worst time ever because that's when everything changes. I've worked in the UK where it's like 16, which is sometimes way too early because some 16-year-olds, specifically males, are not yet ready for transition, right? But then, to keep them to 21 or 23, then the question is, how does that influence your healthcare system, and how can that be supported? Because here at 18, it's the cutoff, and we have to let them go, or you have to ask really specific, exception. But that's usually if a patient has just gone through a transplant process, a kidney transplant for lupus patients or things. So it was very interesting, and still a lot of work to do, but I think a very important topic that was addressed.
What was the last presentation that
I
came to mind?
cannot unfortunately choose otherwise than the soda, because I really think that Dr. Maltese did an amazing job. And I think this is something even because sometimes the sodas are not as applicable for pediatric audience. And I think this was the beauty, that this is also very applicable for the pediatric audience. We also do stem cell transplant in our scleroderma patients. We don't do that many because luckily we don't have that many systemic sclerosis patients, but we have done, in Calgary for sure, in systemic sclerosis, and the CAR T cells also for our lupus patients, especially, again, this transition group where they're going to get lost to follow-up, they're going to actually have organ damage because they are not taking their medication. This might actually be a really good, either CAR T or maybe the BiTEs if we have more evidence. Of course, I think it's a little bit too premature to now say we're going to do CAR T cells for all our lupus patients, but I think there is a future there for certain select groups that we know are at risk of potentially developing severe organ damage because, they'll get lost because they go to university, they decide they don't want medication because they want to drink and party, and then they come back at 20 and they have no kidneys anymore, right? And then if you could potentially, even if it's 2 or 3 years, give them no medication and stretch that and then go back to normal medication, that might actually save their lives, if not at least their organs. So very, very exciting even for the pediatric world. So that was very exciting for me too.
Absolutely. Janet, you were all over the place today.
I had lots
like
that
a hummingbird,
I
flying
was
between sessions.
I was a bird, Janet Bordeaux. But so I'm going to give some comparisons, and I'm biased because I'm an author on at least one of these papers that I'm going to talk about. But the CATCH, so the early rheumatoid arthritis Canadian cohort. So Sue Bartlett, who got a shout out for a great award for a lifetime achievement from Allied Health. As a psychologist, she's looked into various clusters and symptomatology in the early arthritis patients. And between that, and I'm going to talk about Zai Tuma's lupus work in a second because I think there's analogies. Anyway, Sue looked at the symptomatology, and there is a lot of anxiety, depression. It comes with pain. It comes with a new diagnosis. It's kind of all intertwined. And we've known for a long time that some of these clusters can go together of anxiety, depression, pain. But I think what was very disturbing is how common it was. It was at least 1 in 3 patients, and that their outcomes were far worse. Although they could respond to change, they started worse, so they ended worse. And so the chance of them getting into remission was really low. And the burden of how they said their quality of life was very poor, more like people with, say, cancer or other very serious illnesses. Then comparing that when Zai Tuma did a study looking at work and I guess ability to work, inability to work on over 400 lupus patients throughout Canada. And I might be an author on that, I'm not totally sure, but I think we did that project anyway, because this could have been a spin-off of it. But when he looked, he found that, again, not everyone, but a significant minority, again, about a third, maybe a bit more than that, it might have been 40% or so, of patients who rated their quality of health, their quality of life problems as bad as people, again, with cancer, with osteoporotic bone disease that was severe, things like that. So I think we sometimes underrate and under-ascertain in lupus, in rheumatoid arthritis, and other chronic diseases the huge health burden that these patients are suffering with. And if we're not recognizing it, and it's difficult then to help the patient through it and to acknowledge for their family, but I think other healthcare providers aren't recognizing it because we are the specialists kind of looking after them. Sometimes they're primary specialists. And I think that we have to address this. And it's not going to be just take another pill, or it's not going to even be I'll diagnose you early. I think we really need this multiple model of the biopsychosocial, and that we really probably have to have healthcare that puts money behind these sorts of models that will help our patients be the best they can be. So both those abstracts, it was solemn. I really have a take home that I think we can do better for our patients. Moving on, I thought, again, this is a bias because I was in a workshop, so I couldn't go to other workshops. But
Right.
we did on behalf of CIORA, because I chair the research committee. So the research committee, we had a workshop on knowledge exchange and translation, so KTE. And because of that, I had to read a lot about this area, and it's a real problem, because the problems that were identified in the workshop, because I did make the group work, they were in small groups and had to come up with some, not solutions, identify problems, the odd solution as well. But we can't keep up. And if we're subspecialists and we can't keep up, and then we said, well, what does keeping up mean? Is it enough to know guidelines and then we don't practice them anyway and justify it? Because often subspecialists say, oh, the guidelines are for, those who don't do this all the time, but I do it all the time, so I'm just going to ignore that. I think the grade methodology didn't work right, et cetera. So even with guidelines, there's no guarantee they're implemented, and they're not even implemented by the experts that worked on them. That's one problem. Keeping up in general, we talked about should journals be open access, and there was a 50-50 split. No one said no, but I said yes, or yes after a while. And the yes after a while was to protect the papers, that the public wouldn't get their hands on them as easily until it had sifted through some scientific debate, which I thought was an interesting but a bit of a weak argument. The ones who were for was, let's get everything out there, because how do we disseminate knowledge if it's not readily available? So we talked about that. And then we talked about special populations are visible and invisible minorities, pregnant women, people who identify different in gender or in sexual orientation, and what it's like to do research if they might be at a higher burden, how we should really accomplish, I think, really a good communication strategy that people don't feel used, and commenting back when you get the results, so people again feel that they've contributed to science and that what they've done is worthwhile. And we really talked about the fact that we don't know who is supposed to do knowledge exchange. So should it be the researcher? We have no money. Should it be the universities? Should it be the journals? Should it be the granting agencies demanding it? And so who are we to exchange it to? The stakeholders, the patients, the colleagues, the primary care, the allied health. So it's a big topic, and I think even though we have all this social media and all these things in our face, it's not changing our behavior. We still don't translate we don't translate most research very quickly, if at all, into action. So I learned a lot doing the workshop, and I think the contributors at the workshop really helped me crystallize this a little bit better. I still don't have solutions, though.
I mean, one solution could be to put a ton of money towards podcasts. And
yes, well, we did talk about podcasts and tweeting and YouTube and maybe even TikTok.
Okay.
Before it's banned.
Even I'm not on TikTok. So I had two sessions that I just wanted to mention. So Dr. Kim Legault did a really excellent CNS vasculitis talk that I attended, and I do take care of people with CNS vasculitis, but I definitely learned a lot. And because she was so generous with her time answering everyone's questions, she got through maybe a tenth of her slides, and it was a really great talk with a lot of practical tips. The other was Dr. Megan Barber and Dr. Regina Midlarski did a Rheum Derm talk together that was just like really well put together. And just one little clinical pearl that came out of that was that in dermatomyositis patients, about 25% of patients will flare their skin disease if you start them on hydroxychloroquine, particularly if you're SAE subtype, which was a surprising thing to say, because I think a lot of people reach to hydroxychloroquine for skin disease and see it as kind of a helpful agent. So brilliant talks today, and thank you all for summarizing those for us. So before we wrap up, what are you both looking forward to for day 3 of the conference?
Well, of course, I'm looking forward to the Dunlop-Doddridge lecture by Dr. Daphna Glatman on the road to a new horizon in psoriatic arthritis. There will be many workshops, again, too many to mention, but I'm sure there's going to be fantastic opportunities. And then we will have a distinguished investigator keynote address as well from Joan Wither, which I'm really looking forward to, towards personalized medicine and a more targeted approach to prevention and treatment of the systemic autoimmune rheumatic diseases.
I completely agree. I think those would probably be my top 2 highlights as well. But I think the podium sessions are going to be starting bright and early, not to mention the controversies in rheumatology, which I think will be really interesting because I think they're going to be talking about SPA-related controversies, and they're going to talk about should JAK inhibitors, should IL-17 inhibitors and TNF inhibitors be utilized as first-line therapies or not in SPA, which I think is something that's useful, especially now that we have all these advanced therapies that are available to us. So I think that's going to be helpful. And then the second thing, of course, is that there will be these abstract sessions. So today we had our first one. I thought it was a success. I think there will be another one, actually 2 tomorrow. So so that should be hopefully also successful.
And I'm looking forward to the dance.
Always.
Yes.
And I'm looking forward to you at the dance. So that's it for this special ASM edition of Around the Room from Calgary, Alberta. A special thanks to the podcast team, Dr. Dax Rumsey, Dr. Janet Pope, Dr. Mo Osman, Dr. Marinka Twilt, David McGuffin of Explore Productions, and Aaron Stewart. Our theme music was composed by Aaron Fontwell. For more information on the important work of the Canadian Rheumatology Association, visit rheum.ca and be sure to follow us on social media. I'm Daniel Ennis, and we'll chat again tomorrow.
And that's a pod.